Everybody. Today we're going to talk about financing healthcare in the United States and about where the money comes from. This class will help you in describing the organization, structure, and function of the U.S. healthcare delivery system. It will help you compare our healthcare system against other international healthcare systems, and it'll help you think about the role of and different functions of state, federal, and city agencies and regulatory systems in protecting health. Today, we're using the SHE-QUAD model, components of a healthcare system, and we're starting with money because the best way to learn any system is to follow the money, follow the financing. Where does the money come from? And in general, healthcare financing is the component that provides all of the financing to pay for healthcare services. And the World Health Organization defines it as the function of a healthcare system concerned with the mobilization, accumulation, and allocation of money to cover the healthcare needs of the people, individually and collective in the health system. Now, how much money are we talking about? In 2021, in the United States, we spent collectively $4.3 trillion on healthcare. That's almost $13,000 per resident. It's 18% of our total gross domestic product. Now, this amount increases each year, but the percent of gross domestic product has really stayed stable over the last several years. But how much is $1 trillion? It's really hard to imagine, right? So I thought this diagram might help. If you won the lottery and you won $1 million, if you won it in $100 bills, you could pile them up behind the chair you're sitting in, and that would be your 1 million. But what if you won $1 billion and you piled them up in $100 bills? Well, the Burj Khalifa is the world's tallest building located in the United Arab Emirates in Dubai. And your pile of money would be slightly higher than that building. It would be like 2/3 of a mile high. All right, what if you won $1 trillion? Well, if you won $1 trillion, your pile of money would be way out in space, 631 miles out there. So when we're talking about trillions of dollars, we're talking about a remarkable amount of money. So where does it come from? Now, 49% of this comes from the U.S. federal government, some state and some local, which of course means it comes from us, the people, through taxes and through corporations and corporate taxes. 27% of that money comes from households, and that's in terms of copays, of over-the-counter expenses, of things that insurance doesn't cover, and of course insurance premiums. 17% comes from private businesses, both in the money that and they match when they're paying for health insurance, and 7% comes from other private sources. Now you'll notice that health insurance isn't on here because none of the financing comes from health insurance. We gather up all of this money, and then the next step is that we give it to the health insurance companies largely to manage. But we'll talk about that later. But just remember, health insurance is not a source of financing for healthcare. So where does the government share come from, right? So 46% of that government share is directly from us, general funds, income taxes. 36% is from Social Security and Medicare. If you look on your payroll pay stub, we all pay into Social Security, we all pay into Medicare. 11% only comes from corporate income taxes, 3% is from various other taxes, and about 6% is from estate and gift taxes. All right, so that's where the money comes from, but who pays out the money? We're going to spend a little bit of time on this graph because you can see a lot of history here. So how does the mix of payers change over time? So in 1960, 21% of all healthcare dollars spent came through private health insurance. And again, remember, they're not a source of the financing, but that money was largely coming from individuals buying health insurance and some from companies. In 1960, almost half of healthcare expenses, 47%, were out of pocket. Now, in 1960, there was no Medicare and there was no Medicaid, right? But there were other public health insurances programs. So there were largely county hospitals, state hospitals, county and state and city psychiatric facilities. So that's, you know, 6% came from that. About 15% of healthcare dollars came from other third-party payers or public health funds, and about 9% came from investment. So that's 1960. Look what happens in 1970. Where the red circles are where I've circled the share from Medicare and Medicaid. So in 1965, Medicare and Medicaid come into play. For the first time, the government becomes a big payer. And you can see the share of total health expenditures from the government increases over time by a lot, and the share paid by individuals decreases a lot. The share paid by insurance, which is again private insurance, the premiums are paid mostly by employers, some by individuals, that also increases. That increases because in 1972, it was really bad inflation. And the US government froze wages. Nobody was allowed to raise wages. Well, if a company can't raise wages, how are they going to attract people to come work for them? They increase benefits. So we see a big jump in health insurance benefits. We see a big jump in pensions. But for us, the critical thing is that more and more companies after 72 started offering health insurance as a benefit. The shared pay by other third-party payers goes down a little, and the investment share goes down. But the important thing really to note from this slide is that as soon as the government becomes a payer, more and more of the national healthcare expenditure is coming through the government. And I know this slide only goes to 2012, but if we look at this slide, the distribution of expenditures really doesn't change that much over time. Okay. Now, healthcare expenditures are increasing steadily each year, no matter how we look at it. We can look at overall expenditures, right? So from 1970 to 2020, the health expenditures increased, and you might say, well, of course they increased, right? Because things cost a lot more now than they did in 1970. But if we hold that increase in constant 2020 dollars, expenditures still increased by a lot. The rate of expenditure has decreased. The rate at which health expenditures is increasing has decreased, but health expenditures are still increasing. So what drove this up, right? Why are we spending so much more collectively through all our different financiers on medical care and health care than we did in the past? Well, there's not one factor responsible, but I'd like to cover some of the major ones. First, there's increasing unit prices of medical services. There's more intense level of service provision. There's more sophisticated medical technology. There's more of us here, bigger population. Population's getting older, so there's more chronic disease. And finally, a chunk of our expenditures, private insurance in this country is largely a for-profit venture, and so are many healthcare systems. So those overhead costs are part of what's driving up costs. And finally, we're simply willing to pay more for care than other countries. So if we look at unit pricing, and I really like this slide because we can see the consumer price index, right? Like what happened, which units increased over time. So if we look at the red line, medical care from 2000 to 2022 increased in absolute cost much more so than anything else. Housing's close behind, but then if we look at apparel, the price of clothing today is actually cheaper than it was relative to our income in 2021, I guess, than it was in 2000. So the unit price of goods have increased for healthcare much more so than for anything else. And we might say why. Well, part of what happened, and let's spend a little time on this graph as well. Part of what happened is that the level of service intensity has increased as well. So most of us, right now, something like 92% of the country has some form of health insurance, Medicaid, Medicare, private insurance or the exchange, or military or VA. So most of us, how do the doctors get paid? They get paid by the level of intensity of a visit. So a level 1 visit might be something like a prescription refill where I call the office, I might not even talk to the doctor. A level 2 visit might be something really quick. Maybe I had I'm having a TB test. I come back to have the TB test checked. Doctor or nurse looks at it. Level 3 visit is a visit where I come in with something acute. Maybe I might have strep. I might, be having stomach pains. Maybe I threw my back out. Level 4 visit requires more time, more care. Those visits usually have to do with chronic disease. And a level 5 visit would be somebody with multiple chronic conditions who is very complicated that required a lot of time. So essentially, the more time a physician has to spend with somebody and the more they have to do, the higher the level of visit, but also the more they get paid for it. So if we look over time, most visits were level 3 visits, right? And as we go from 2003 to 2021, more and more visits are getting coded as level 4 visits, which are more expensive. That's intensity of care. Another reason, US population went up. We went from 311 million to 329 million. So the absolute amount of money that we're spending is going to increase because there's simply more of us. But per capita increases also went up, and that controls for population. So again, if we look at national healthcare expenditures, over time, they're increasing. So another reason for the increase in healthcare expenditures overall is that we're aging as a population. Now, if you haven't seen a population pyramid before, they're pretty cool. They're a visual way to show the age and gender structure of a population. So if you look at the pyramid from 2000, you can see that, for the under 5 males, there's a little right around 10 million males, right around 10 million females. A little bit more for 5 to 9-year-olds. If you look, you can see the lump at the 35 to 39 that goes to 40 to 44. That's the baby boom, right? That's the baby boom born 1946 to 1964, and that's them in the year 2000. And you can see that we don't have as many elderly people in 2000 as we do today, right? That the bulk of our population is middle age. You go to 2010. You can see our population pyramids assuming a more rectangular shape, which is indicative of an aging or older population. And then finally, 2020, you can still see the baby boom, which I think is pretty cool that you can see it come all the way up through there. But you can see that we are very definitely a larger proportion of our population is older. Another reason is insurance company overhead. Now, this is really interesting. If we look at the total healthcare insurance company compensation in the last 10 years, Cigna paid $365 million just to their CEO. That's a lot of health insurance premiums to pay one person. And you can see that we're talking about over $300 million for Cigna, for United. For the other groups it goes down, but they're still in the 100 millions. And just to put a face on it, here is what the health insurance CEOs got paid in 2018. Again, that's a lot of healthcare insurance premiums. Now, it's not just the health insurance companies' overhead that's high because of very high payments to CEOs. If we look at the CEOs of the major healthcare companies, we can see that they're making 21 million, 20 million, 14 million. Again, that takes a lot of patient payments to come up with all that money just for one person. For-profit hospital systems, hospital overhead is as well too. We look at University Health Systems, head of Universal, Health Systems. Alan Miller takes home 51 million in 2018. So you can go down the list. Hospital Corporation of America, a for-profit hospital system that's rapidly growing in the South, HCA. Their head takes home 17 million a year, and so on. Physician salary. Now, there are a lot more physicians, and when we look at the healthcare expenditure pie, the second highest expenditure is for physicians. Overall, each individual physician makes about $339,000 a year. Primary care providers are way underpaid. They make about $100,000 less. Specialists make more. We'll talk more about this when we talk about healthcare providers. Financing. So other factors that contribute to increased spending. Part of it is that we treat healthcare as a free market good, and as we know from previous lectures, it's simply not. So all of the normal controls, that pressure that would exist on price due to interactions of supply and demand, they don't work. The healthcare legal environment. In the US, we're more litigious than other places. So physicians have to buy insurance because they're going to likely get sued. Fraud and abuse. There have been many, Medicare and Medicaid are especially prone to this, but so are private insurance companies. And also because of clinical specialization, we have a lot more specialists than primary care doctors in the US. Specialists are just more expensive. Now let's think about it a different way. So the first half of this lecture, we really talked about where does the money come from? Why is it so expensive in the US? Why are we spending, over $4 trillion on healthcare? But another way to look at financing is saying, well, how do we as individuals pay for care, right? So about half the US pays for care through their employer. And that's the single, so for a lot of us, we look like Germany in that we have employer-based insurance. About 6% of us directly purchase private health insurance. The great majority of that is through the healthcare exchanges. 20% of us have Medicaid, 14% have Medicare. There's some overlap in that people have both. I put the overlap numbers in Medicare, so some of the 14% in Medicare additionally have Medicaid. About 1% of the countries in the military gets their health insurance through them, either VA, direct service, or a dependent, and about 9% of the country is uninsured. Folks who are age 65 and over, 97% have Medicare, 11%, a little bit more currently, are also what are called dual enrolled, meaning they have both Medicaid and Medicare. A lot of folks on Medicare also have private insurance because, remember, Medicare only pays 20% of the costs of outpatient care. And a lot of folks don't necessarily want to be at risk for the rest. And so they'll get insurance through AARP or some other, United also sells it. And they'll have Medigap insurance, which covers the difference between what Medicare reimburses and what they need to pay out of pocket. And only about 1% of the elderly in the US are uninsured. Now, how do we compare to other countries with financing? And this is really the thought I want to leave you with. We pay $12,000, almost $13,000 per person for our health care. This is almost twice as much as the next most expensive country, Germany. It's twice as much as the average. And you would think, is it really a bad thing for a country to spend 18% of its gross domestic product on the health of people that live in the country? Is spending $4 trillion on the health of our population bad? Not necessarily, but there's a big but coming. But we don't get our money's worth. So we spend a lot more money, but we have, compared to all of these other countries, we have lower life expectancy, higher rates of chronic conditions, higher rates of obesity, and higher rates of infant mortality. So for all of that extra money we're spending, we're not seeing a benefit. And that's really the problem. So our next step is health insurance, and I invite you to watch that lecture as well.